Still got mighty quiet. That's the same problem. Hey, give me a it's on my. Good morning, everybody. I apologize for my late entrance, but long story short, we got here. Let me thank and welcome everybody here to the Alabama Rural Health Transformation Program Roadshow Workshop. My name is Kenneth Boswell, and I'm the director of the Alabama Department of Economic Community Affairs. Governor Ivey has tasked my agency with administering the program. The funding comes from the Center of Medicaid or Medicare Medicaid Services as part of the One Big Beautiful Bill Act. Since last fall, ADECA has worked closely with the governor's office, the legislature, CMS, and many others to get the program started. We've also been working with the governor's Rural Health Transformation Advisory Group, and we're pleased to have here with me Senator Donnie Chastain with us today, and he chairs the advisory group. DEC is dedicated to ensuring that you have the resources, information, and support needed to fully understand this program and its initiatives in order to prepare and submit your competitive applications. Let me take just a moment and recognize my team. Crystal Talley here to my right. She is the division chief for the Federal Initiatives and Recreations Division, but she is going to be the lead from the standpoint of program implementation. Then we have Ashley Toole in front, that's my deputy, Richard DeWeese, which is our general counsel, and Latoya Edwards, which is Crystal's counterpart. Let me also say that you will probably have questions after this program. We will be here to answer those questions to the best of our ability. But no, there's some things that we don't know because we are putting this plane together as we fly. That being said, and that we're not kidding when we say that, but there is a site that you can go to that if once you leave here and you have other questions, you can enter those questions into this site, and BDO will have people to respond to you as soon as possible. And that site is info@alabamarhtp.com. I repeat it, info@alabamarhtp.com. All right, this workshop today will provide an in-depth overview of the program and the 11 initiatives developed by Alabama. We will begin the presentation with BDO, our contracted consultants who are assisting us with the program. You will then have an opportunity to ask questions. There are two key words to remember, two of them now. And it's not our rules, it's CMS's rules. Transformational and sustainable. Transformational and sustainable. You need those in your application for you to be looked at on a real strong basis as far as an award. Let me also introduce the BDO team that's here with us today. David Long, then we have Sam Taylor, and we have Laura Russell. All right, we're recording one of these workshops, and we're recording this one as we speak. We plan to have it on our website in the near future. That way, if you have to refer back to that, you can at a later date. Speaking of the program's website, I highly encourage you to visit it as the program moves forward. The URL is alabamaRHTP.com. You can also join an email list on the website to get important updates as information as the program progresses. Again, thank you for being here and having interest in this program. I'll now turn it over to David Long.
Thank you, Director. Thanks to everyone who got this morning. It's great turnout. So great turnout that we had to do a last minute venue change. So thanks for everybody for being flexible for that as well. So what we wanted to go through today, and Hopefully my clicker is working. There we go. As the director said, our goals for today is to provide an overview of the Rural Health Transformation Program, really at the national view, what CMS's approach has been, how they're interacting with states. And then next, we'll dive into Alabama's specific Rural Health Transformation Plan, including the 11 key initiatives, allowable uses of funds, and some program timelines. And then finally, we'll dig into what Alabama expects from potential applicants and what are some next steps as we're looking forward to the next weeks and months of the program. So the Rural Health Transformation Program, as the director mentioned, was formed out of the One Big Beautiful Bill in July of last year, and it is being run through CMS. The director says, the state is building this plane. CMS is in the same boat. They are still building this program even after it's launched. We're going to get continued updated new guidance. I know many of you deal with CMS on a regular basis, so you know the ups and downs that can go with that. And so just kind of wanted to set that context that this is a brand new program. Things are still getting figured out. But we're running as fast at it as possible. So back in the fall, Alabama submitted their state's application to CMS, and then that's where they got approval of these 11 initiatives that are in the state's plan, as well as notification of their first year allocation of funding, which is roughly $203 million. So how the program will work is, as Alabama makes determinations on subrecipients receiving these dollars, they will then kind of go back and draw down those funds from CMS and then get it down to the local folks. The goals for this program is to move beyond short-term stabilization dollars and really make this long-term system redesign through targeted investments into rural healthcare. CMS has listed 5 strategic goals, and really this was kind of what they tasked each state who applied for these funds. Probably unsurprisingly, 50 out of 50 states applied to be a part of this program and were accepted. But this was kind of the driving strategic goals that CMS asked each state to formulate their plan around. So the first was make rural America healthy again, improving rural health outcomes through expanded access, focus on preventative care, behavioral and chronic care services. Next is developing sustainable access, helping rural providers become long-term access points for care by improving efficiency and sustainability. Really, the theme here is how can these dollars go towards investments that can help ensure as much care stays as close to home for rural residents as possible. Workforce development. How can we use these dollars to grow and support rural healthcare workforce through recruitment, retention, and training? And when we talk about rural healthcare workforce, it's the full gamut from physicians, nurses, staff. It's really kind of the full type of provider types. It's open and very comprehensive. Thinking through innovative care. How can we use these dollars to build and incentivize models for value-based care, care coordination amongst rural providers, and overall things that can improve care quality and try to target reducing costs for our providers. And then finally, tech innovation. How can we use these dollars to expand the use of technology to improve access for patients through things like telehealth, facilitate data sharing so that it can help drive care coordination and other care services, improving cybersecurity and other just overall health IT needs, and providing remote care, remote patient monitoring devices in homes for folks as makes sense. So I'll reiterate the key words that the director said in his opening. And again, this is something that we hear basically every time we meet with CMS. It is the focus of this program. Again, it's not short-term infusion. It's really looking towards transformational things, positive change to the structure, character, or function of what we're doing in rural healthcare. And then ultimately, sustainability. How is this thing going to be maintained and continued beyond the 5 years of funding for this program? This might be a little bit difficult for people to see in the back, so I'll do my best to summarize it. But wanted to say this program, again, is a 5-year program, and it runs on the federal fiscal year, which runs from October through September. So it kind of splits calendar years. When you're thinking this program started in October of 26, states hadn't even been able to submit their applications then. So year one is a little bit of a truncated timeline, which is why we're running very fast at this. But we will have to award year one dollars, again, that $203 million allocation, award those to subrecipients by the end of October of this year, October 30th of this year. So that's kind of our window for all of our applications and getting all of our dollars awarded. Once an organization is awarded, they have until the end of the following fiscal year, so which would be September of 27, to spend down the dollars for program year one that they've been awarded. So when you're thinking through how you structure your application and how you structure your proposals, we really just, by the function of this program, have to think somewhat discreetly in year increments. We know and appreciate and hope that some of these efforts are multi-year efforts, but you have to kind of think through the sequencing and budget of your proposal of kind of what can I get done between now and the end of September 27. And then during that time where you're doing dollars of year one, cycle of year two applications, we'll have our year two allocation. So it's a little bit of kind of a rolling cycle that we'll have to keep up with. Wanted to dig into at a pretty high level. This is not an exhaustive list, but I think these are likely the kind of the most common considerations. Again, this is structural set forth by Congress and CMS of allowable and unallowable uses of funds under this program. So on the allowable uses, workforce recruitment, training, leadership development, CMS is eagerly anticipating that. Targeted renovations for facilities are allowable under this. And kind of the term targeted means that these renovations have to be in service of the initiatives, have to be in service of those 5 strategic goals that CMS put forward. So it can't just be any type of renovation that you would hope to have. It's really renovations in service of this program. Dollars for care delivery redesign and service expansion, investment dollars for telehealth and health IT infrastructure, funding dollars to support care coordination, clinically integrated networks, and other collaborative models that the state is hoping to see throughout this program, and ultimately planning for long-term sustainability. Some unallowable uses. So this program does not allow these dollars to go towards things like paying down debt, covering operating expenses or losses. These dollars cannot go towards new construction. So again, while targeted renovations are allowed, no new construction under this program. These dollars can't go to supplant any existing funding sources, public or private. Again, per CMS, the state cannot fund proposals without sustainability plans. Kind of talking about what is the work and how's the work going to be accomplished and paid for after year 5. And then finally, kind of the real ultimate backstop is these dollars have to go towards activities aligned. So anything that's not aligned with approved initiatives of the Alabama Rural Health Transformation Plan or any other kind of CMS functional requirements will not be allowed. There are some funding constraints for some of the allowable funding uses. So provider payments that are in support of initiatives are capped at 15%. Again, these dollars have to go towards supporting the initiatives, but there's instances where provider payments might make sense, such as kind of a common example that CMS likes to give is If we're introducing new telehealth services into a community, but that's not currently a type of telehealth that's reimbursed from any of your payers, we can use some of these dollars to kind of cover that lack of reimbursements. Again, just over the 5-year period of this, but that is capped at 15%. Capital improvements, the targeted renovations, they did put a cap at 20%. And this is percentages of the total state allocation. So think about this is the percent of that 203 million. So still some decent amount of dollars there available. One more funding constraint is there's a pretty heavy cap on electronic health replacement, electronic health record replacement, meaning if you're an organization that's already on a high-tech compliant EHR, the state only has 5% of their funds available to get folks on a different electronic health record. But when it comes to, improving your current record, getting new modules, doing updates, and also for practices that are out there potentially still on paper, if you're transitioning someone from paper onto electronic health record, that's not capped. It's really just going from one EHR to the other. And I think a lot of the thinking behind heavily capping this is, a $50 billion program. If it wasn't capped on getting on new HRs, I think Congress knew that this would be $50 billion going to Epic, and they weren't going to grant a monopoly through this fund. So digging into Alabama's state plan and the initiatives and the vision behind, what the state applied for again back in the fall. So Alabama's vision for their rural health transformation program, again, is supporting rural healthcare providers and delivering technology-enabled, sustainable, high-quality care close to home. Program prioritizes access, outcomes, and sustainability, using these targeted investments to enable new models of care and workforce pipelines for Alabama's rural citizens. And kind of an overall theme for this transformation plan is tying to broader goals of healthier populations in our rural communities, stronger overall workforces, and local economic resilience. I think we all know and appreciate that in our rural communities, our healthcare, our hospitals, our clinics are one of, if not sometimes the main employer in a rural community. And so there's a halo effect. If you're making these healthcare providers stronger, you're making the community stronger and more resilient. We'll dig into, we have a slide committed to each of these initiatives, but kind of wanted to put up the full list. Again, there's 11 initiatives that were approved by CMS that Alabama included in their state plan. The first is the Collaborative EHR, or Electronic Health Record, IT and Cybersecurity Initiative. The second is the Rural Health Initiative. The third is the Maternal and Fetal Health Initiative. Fourth is the Rural Workforce Initiative. Fifth is the Cancer Digital Regionalization Initiative. Sixth is the Simulation Training Initiative. The seventh is the Statewide Emergency Medical Services Trauma and Stroke Initiative. Eighth is the EMS Treat and Place Initiative. Ninth is the Mental Health Initiative. 10 is the Community Medicine Initiative, and there's a footnote there that you might not be able to see. The Community Medicine Initiative is the one initiative in year one that's not available to apply for dollars. The state's still doing some planning on this, and it will be open and available for funding starting in year two. And again, year two starts in October, so it's not that far out. So we wanted to, mention it here, introduce it here, because certainly there's things that can already start planning for when, applications for that in year two open up. And then the final one is the Rural Health Practice Initiative. So digging into each of these, the first one being the Collaborative EHR, IT, and Cybersecurity Initiative. The objective here is to modernize IT infrastructure and enable secure, interoperable data sharing across rural providers. Key components in this initiative is funding to establish regional IT and cybersecurity hub model, providing dollars for electronic health record integrations and upgrades, providing funding for connection points to the Alabama One Health Record Health Information Exchange, and then finally providing funding to create shared service models for IT services across rural providers to help reduce kind of the individual location costs for IT services. The impact here is to have improved care coordination and patient safety through data interoperability, lower our IT costs, and truly, attempt to raise the level of IT service that rural health providers have, and to provide stronger cybersecurity and system reliability. Next is the Rural Health Initiative. The objective here is to deliver specialty and primary care services closer to home using telehealth and shared services. Key components of this initiative: regional telehealth hub establishments, providing services of teleconsults for things such as stroke, behavioral care, intensive care into our rural communities, as well as providing dollars for remote patient monitoring services. So putting devices in patients' homes so that we can monitor chronic disease conditions and other things remotely. So again, we can intervene as timely as possible for these folks. Equipment upgrades and minor building renovations. That funding will run through this Rural Health Initiative. The creation or expansion of non-emergency transportation systems. Again, helping develop a network of non-emergency transportation so that, in rural communities where folks struggle to get to their regular appointments, struggle to pick up medicine that's important, anything that's, doesn't really require an ambulance. Sometimes the ambulance still gets called. And so how can we build a non-emergent transportation infrastructure? And then finally, funding the creation of a rural health network of shared services for our rural providers so that it can, again, kind of reduce administrative costs and administrative burden through sharing services, and also potentially increase a higher level of service across our rural providers. So the impact for this initiative: reducing patient travel and transfers because we're able to deliver more care closer to home, increasing patient access to specialty care, and improving provider efficiency and overall patient outcomes. Next is the Maternal and Fetal Health Initiative. The objective here is to improve maternal and infant outcomes through digital regionalization. Key components of this initiative: regional maternal care hubs, funding telerobotic ultrasound technology purchase for our rural providers, creating a tele-OB specialty access for things like high-risk pregnancy, have that access for our rural patients, and providing funding to purchase emergency labor and delivery stabilization cards. The impacts here: reducing maternal and infant mortality in our rural populations, creating new access points to high-risk pregnancy care, and stabilizing OB services in rural communities, despite closures of facilities and sometimes just closures of that service line that we've seen. The Rural Workforce Initiative. The objective here is to address workforce shortages through training, recruitment, and retention. Key components through this initiative: expansion of graduate medical education programs and ensuring that those residency graduate medical education programs are located in rural communities. Creating a rural training pipeline that starts in our K through 12 schools, flows up into our 2 4-year colleges and postgraduate training, and having these pipelines focused in the rural communities so that we can identify local talent in our rural communities, because those folks, if they get into training workforce pipeline, are much more likely to stay in that community and serve that community going forward. Funding for remote training for EMTs, emergency medical technicians. Expanding of training programs for certified nurse midwives, LPNs, RNs, and really all other key roles that are serving our patient populations. Recruitment and retention incentives for rural practitioners, and wanted to say, this includes things like dentists, dental hygienists. Again, we want to be as broad a net in what we consider, people who can receive incentives, receive training, We know that kind of all across the board, there's needs for kind of each and every role, and want to make sure that they're included here. And then finally, free or reduced cost education and training for people who commit to 5 years of practice in rural Alabama. And that last kind of phrase there is key truly throughout this workforce initiative. If you're receiving the recruitment and retention incentives, if you're receiving free training that's paid for from this program, if you're receiving this reduced cost, it comes with it a 5-year commitment to practice in rural Alabama. That's something that we will have to track internally for the state, and that CMS is going to be monitoring too. And there's true teeth to this. If someone backs out of that 5-year commitment, these dollars will have to go back to CMS. And so, that's certainly a commitment, but I think CMS wants to have that kind of teeth to this because if somebody is committing to 5 years, they're that much more likely to stay in that community. So the impact here, overall increase of numbers for our rural healthcare providers, stronger local workforce pipelines. Again, a big goal here is to identify local rural talent that we can cultivate at a young age and bring up through training. And this will overall lead to longer-term sustainability for rural care delivery. The Cancer Digital Regionalization Initiative. The objective here is to improve cancer outcomes through regional coordination and mobile access. Key components are regional screening and referral hubs for rural patients, providing and deploying mobile screening units. So again, getting out into the community and providing mobile screening for certain cancer types. Funding and deploying community-based outreach and education around cancer. And also the plan contemplates expansion of some proven statewide models. Some of you may be familiar with some of the state models for cancer screening. They're kind of been in a little more of a regional setting and for certain cancer types. And so these dollars can go to these kind of proven statewide models to expand them to more populations and also expand them to more cancer types being screened. Impact here, certainly earlier cancer detection for our rural patients, increased services and screening in rural areas, and the overall goal is really reducing disparities in cancer outcomes that we see between our rural patients and our urban patients here in Alabama. The Simulation Training Initiative, the objective is to improve quality of care through advanced simulation training. Key components are expansion of simulation-based programs where they are, currently may exist. We can facilitate to provide higher levels of training or new services of training, developing specialty specific skill development for our rural practitioners, and creating partnerships with existing training providers so that they have a dedicated connection point to our rural providers for training programs. The impact here, again, with increased level of service and training of our rural providers, we're hoping to reduce patient travels because they can stay closer to home. Improving local care availability and quality, and overall just increasing provider confidence and capability. Sometimes, anecdotally, I've heard that, there's sometimes just times where local rural providers probably could have taken care, but err on the side of caution and transfer out. And so what can we do to support and train so they don't kind of feel that need to transfer out of their community? The statewide EMS Trauma and Stroke Initiative, the objective here is to ensure patients receive care at the right facility at the right time. Key components are expansion of the statewide emergency medical services routing system, and including some additional conditions in there, like cardiac services, behavioral obstetrics, and then providing funding for a centralized coordination of emergency transportation. So impact here, faster access to appropriate care, improved in survival and outcomes because we're getting faster response times, and overall more efficient use of hospital resources. That we do a better job of making sure that certain ERs aren't getting overloaded, but also making sure that there's sometimes ERs that have capacity that aren't getting it because of the routing system not being able to do it before. The EMS Treat in Place initiative, the objective here is to enable EMS to treat patients on site when appropriate. So Alabama recently passed legislation to allow for EMS Treat in Place services. So when an ambulance shows up to a home, an EMS first responder can make a determination that this person certainly needs some help, but it doesn't quite rise to the level where they have to go to the emergency room. And so they can provide services there in the home to avoid an unnecessary emergency room visit. So this being a new type of service for the state wanted to use some of these rural health transformation funds to help create and deploy treat in place protocol development so that there's consistency of treat in place care across the state, but also provide telehealth support to these EMS providers who are newly providing these treat in place services so that they have some telehealth consultative services if they have a question, want to double check and make sure that they're doing the right things for this patient. They have that capability within their equipment for that telehealth support. And then ultimately providing training and equipment necessary to successfully deliver these EMS treat place services going forward. The impact of deploying to top of license EMS treat in place, reducing emergency room and emergency department overcrowding. And through that, this will likely increase EMS availability for those truly emergent things because they're not making a potentially unnecessary multi-hour round trip with a patient. They're able to treat in place, stabilize, and then immediately go to the next emergent need. And through deploying this, again, lowering unnecessary emergency department visits, one of the most expensive places to take care of our patients. This will help lower kind of the overall healthcare cost and spend for Alabama. The mental health initiative, the objective here, improving mental health service access through integrated care models. Key components for this is funding school-based telemental health programs. The second is providing funding of conversion of community mental health centers, or CMHCs, to certified community behavioral health clinics. So those of you who might be in the mental health world, those are acronyms you're likely familiar with, but for those who might not be, these are essentially outpatient clinic classifications. And the certified community behavioral health clinic is kind of the next, it is a certification from CMS that has required amounts of service, kind of heightened levels of service, levels of staffing for these clinics that are required in order to have that certification. So to be able to provide those services, provide that staffing, there's certainly funding involved with that. And so this plan wants to help provide that funding for the conversion. Because when they convert to CCBHCs, not only are they able to provide higher levels of mental health care to their community, they actually also have access to heightened reimbursement and alternative reimbursement models that are deemed to potentially be more sustainable in the long term. And then finally, providing funding for integrated behavioral and physical health services in our rural communities. The impact here, increasing access to mental health care for rural patients, reducing untreated mental health conditions, and again, through that CCBHC model, funding, providing sustainable reimbursable care models for our mental health clinics. The Community Medicine Initiative, again, asterisk here that this is launching in year 2, but certainly wanted to go ahead and highlight it for you. The objective here is to improve population health through community-based services. The key components of this initiative, purchasing and deploying mobile health screening units into the community Again, not just like a full-scale primary care visit, but screenings for things like prediabetes, other early indicators of chronic conditions. Again, as early as you can identify and intervene these things, the more you increase the long-term health of your community. Mobile food access through things like mobile groceries or food banks. This program, again, one of the key strategies that CMS set forth is kind of the Making Rural America Healthy Again. Food as medicine is very top of mind for this administration and CMS right now. So how can we both educate and provide access to healthy food? And then providing funding for health education and wellness programs in our community. So the improved health literacy for our rural populations, reducing preventable conditions through early intervention and education, and providing better access to healthy food and screenings. The final initiative is the Rural Health Practice Initiative. So this one is focused more on the clinic side. And so the objective is to expand and modernize rural clinics as community care hubs. Key components of this initiative, providing funding for shared services models to reduce administrative overhead specific to our clinics, providing renovation dollars and equipment upgrades for our clinics, telehealth and remote monitoring integration, providing clinic-specific workforce recruitment and training, and funding school-based dental and healthcare clinic partnerships with our communities. The impact here, increasing access to primary care and preventive care for our rural communities, integrating physical and behavioral health services, help bridging that gap, and then ultimately providing stronger, more sustainable rural clinics and practice sites across the state. So diving into some program details and timelines, wanted to detail who is the state expecting to apply for funds. Not a fully exhaustive list, but this is pretty comprehensive of who can apply for funds. So certainly rural hospitals of all classifications, PPS, critical access, rural emergency, all on the table. We've gotten questions in other sessions. For-profit entities are just as eligible as nonprofits in this. Many physician clinics and other sites are for-profit. Health systems with rural footprints, clinics, federally qualified health centers, rural health clinics, all on the table. Emergency medical service providers, mental health and post-acute providers, and then especially for things like workforce and community engagement, we anticipate educational institutions, nonprofits, and other community partners to play a role in this transformation. How organizations will apply. So notice of funding opportunities, or NOFOs, will be released starting in June, which is next week. So starting next week, some of the first notice of funding opportunities will be released. Organizations can apply individually or together as collaborative efforts. And organizations can apply for multiple initiatives. If you want to, all 10 in year one. But you're not just pigeonholed into just picking one. But just once again to reiterate, these applications and your proposals must align with the state's plan, all CMS requirements, and overall goals to impact rural healthcare in Alabama. A lot of those kind of expectations, CMS requirements, will be kind of listed through the notice of funding opportunity and throughout the application process. A timeline for year one, we're here in May. This has really been kind of the month of stakeholder engagement and education that has culminated in these roadshows here in the last week of May. And then again, in June is when the first notice of funding opportunities will be released and applications should be submitted. July, that first round of applications will be scored and potentially determinations will be made. And also further notice of funding opportunities will be released in a pretty quick, rapid succession after the first ones that are released next week. In August and September, we anticipate that all 10 notice of funding opportunities for year one will be released. And that by August and September, those folks who applied for some of the dollars in June, that some of their activities are underway. And the reason for that is program year one reporting to CMS that the state has to deliver is due at the end of August. And that's the case for every state across the country. And so the most forward momentum that we can show we're making in the program by August is going to set the state up to receive just as much, if not more funding in the future. The state isn't locked in to receiving the exact same amount in years 2, 3, 4, 5. CMS is really going to look and evaluate, how is this state done in administering the program, which is our job. And then how have the subrecipients done in getting started in the work that they're trying to do to transform rural healthcare. Again, in October of 2026, that's when all year one dollars will be obligated. Again, by the end of October, by the 30th, technically this year, because Halloween is on a Saturday. And then in October, again, that's the start of the federal fiscal year, which means it is the start of year two of this program. So the state will get notice from CMS of what their year two allocation of dollars are, and we'll start the process over again of releasing notice of funding opportunities for those year two dollars, and hearing from you all in the second round or the second year. So some immediate next steps for potential applicants. So as these notice of funding opportunities are released, we will be hosting workshops here in Montgomery for applicants to attend in person as well as virtually. We know that not everybody who's interested can come in person, but we want to make sure that as many people as possible can attend these workshops to cover the details of the notice of funding opportunity, as well as details on information for how to apply. All the application process will be an online process. There will be a portal that's linked to the website URL, but that'll all kind of be listed out as detailed information in the notice of funding opportunity. During the application windows, my team will have staff ready to give technical assistance as needed to applicants to ensure applications are complete and compliant. Those are really the main factors of technical assistance. We can't help you write your application, but we can make sure that what you're submitting is as complete and compliant as possible, so that it'll be fairly evaluated and scored by ADECA. ADECA will continue to update information both on the program website. Again, it's alabamarhtp.com, as well as through email. You can sign up, as the director said, to be on the listserv on the website. And again, if you have any questions in the interim, as you're leaving today and you said, man, I wish I thought of that, thought to ask that in the room, that info@alabamarhtp.com is the email address that we'll take your questions into. So went through a lot, and certainly want to make sure that we have plenty of time for questions. So I think with that, we'll open it up to y'all for any questions you might have. I think my recommendation would be submitting for multiple initiatives. Again, kind of the structure of the program and reporting is on an initiative by initiative basis, which is why we're releasing the kind of initiative specific notice of funding opportunities. But essentially kind of your ask will just be lighter or heavier, depending on what your focus. And also, we fully anticipate that folks will be applying for multiple initiatives. And so through the application process, we'll have kind of an organizational level view so that we can see that you've applied in multiple places. And certainly, welcome in your application narratives to kind of mention, hey, also, this is going to be kind of woven together with initiative XYZ, just so again, we have as clear a picture as possible what your goals are with these dollars. Yes.
It's over into year 2. Do you reapply for that with the same NOFO that's released for year 2?
Correct. There'll be that's again just kind of a functional reality of this program. The state can only allot year 1 dollars in year 1, and again they have to be completely spent down by the end of the federal fiscal year of the next year. And so, kind of high level guidance I can give: think as discreetly as you can in years, but certainly let us know that this is an effort that we anticipate going into future years. But there will be a requirement to reapply each year. Yes.
Just to clarify, that deadline end of June? When's the deadline?
Deadline for, so that will all be detailed in the notice of funding. So next week we'll release the first batch, and it will be the 5 highlighted initiatives will be released next week. And I believe we said the 26th is the due date for that first round. But the next ones that come out will also have that kind of 4 to 5 week range going forward.
But
Yes.
you feel like broadband infrastructure have a place. Can't tell them that.
I can actually, working on that, we're actually working with our consultants now and our internet service provider. We feel strongly that we're getting this information to BDO in order to take them for those that don't actually have the service yet. Then we feel like in 2 years from now, it'll be up and running and hot.
And that's, I didn't list that in kind of the unallowable uses, but we've been pretty strongly directed from CMS that these dollars can't go towards broadband expansion, because I don't think they wanted to avoid blurring the lines of that BEAD program. But I think a nice thing about this program being run through ADECA is they also have heavy insight into that broadband expansion initiative. So we're going to be keeping close tabs on it to make sure that they can be as coordinated as possible.
You're asking about telehealth, and if you'll have the infrastructure in place at a particular point in time. We have already got our consultants working on that. It is compiled, and we have got it to our video consultant.
Yes.
Deadline 30th. Just said it was on June the 25th.
I think we said the 26th in the legislative council meeting last week, Crystal.
NOFOs will be issued on June the 1st. So you need to look at the NOFO and see the date that is identified on each one.
It will, depending on when the NOFO is released, not all 10 are going to be due by the end of June. So it's just this first round that's going through. But yeah, I think we're finalizing that, and it will be definitive on the notice of funding opportunity when it's released. Yes. Will they all be like the same narrative? Yeah, I think, yeah, multiple from the same institution is more than fine. Yeah, back.
Funded the program located, for instance, into some rural county. What is the sustainability that required?
I mean, we can't dictate what your sustainability plan is. But it's, you know, what other funding sources are, you know, what other potential plans that folks have to continue the effort. But I don't think.
But that is left up to you to actually come up with that. We're just going by what CMS is asking us to do. And it's up to you to actually provide the proof of sustainability.
Yes.
David, what is the process? I believe BDO will grade them and it goes to CMS, and is the legislature, does it come back to them for any points?
What'll happen unless it changes. And I've injected it every one. How many dealt with CMS? Show me a hand.
How many deal with
What I'm
CMS?
saying. Y'all understand the level of difficulty. Going back to your question, it's our intention to take the applications, grade them internally, and then it will go to CMS, and then CMS will have the final say. They can either alter it or either take and leave it in its final state or just say absolutely no. So I hope that answered the question.
Yes.
In June, but the program reporting is due August 31st. Like, am I applying for a project that will run? What? I don't understand the timeline, I guess.
Yeah, it's a little bit of a just difficult timing thing, but by the nature of this program being brand new, and as the director said, CMS is still building this plane. The CMS had to establish some type of reporting cadence. So you're not wrong in saying, like, what will we have to report on by August? But I think we'll have a handful of things that we can say that we have awarded dollars for these proposals. These are the proposals that we have. Here are the goals. And so, you know, how much are we moving the needle? And every state is facing this. Every state saw the reporting and said, August of this year is when I have to report to CMS. But that's just kind of how these programs have to be. They have to establish a reporting cadence, because then starting in year 2, there's quarterly reporting back to CMS. So I'm sure many of you have, you know, joined some, you know, Medicaid innovation model year 1. You know, there's a lot of startup that goes into it. But our hope is that CMS will be as reasonable as possible in that. But I never like to predict what CMS does. No, I would think about it in the spending timeframe, which is you have until September of 27 to spend it down. That will count as year 1, correct? You have roughly a year to spend and do those activities. Here. Separate applications for each initiative. In the back, gentlemen. You are not. So anything that has been expended before you have a notice of award in the program cannot be like retroactively reimbursed. It's all efforts moving forward. Yes, here. Yeah, yes to the first. So each notice of funding opportunity will have kind of the total amount that the state has budgeted for that initiative. I don't think we're going to say definitively X number of awards are going to be given for that. We really want to see the totality of the universe of applicants and make determinations from there. But you'll see kind of the maximum funding per initiative so that you can kind of right size your budget ask to that. In the back. Yes. Yeah.
Numbers, but can you applications within the same initiative if it's geographically distinct, or would you?
If it's for the same activities, I would do one application.
The second question, this be a reimbursement model?
This will be we're kind of calling it a modified reimbursement model. So if you think through maybe some of you who've dealt with some other grant programs, there's kind of a requirement to have spent your own money in order to be reimbursed. What CMS is allowing here, because they acknowledge that some organizations who are applying for these dollars might not necessarily have the liquidity to do some of the things that they're asking for in the proposal, is really looking at it through reimbursing an incurred cost. So that, for instance, if you apply to get some type of technology equipment, your organization will need to go through the procurement process, select a vendor, and get essentially an invoice from that vendor for the actual cost that you're going to spend. Then you can provide that proof of incurred cost up without actually having spending your own money. And the state can then draw down those funds to give to you to then ultimately pay your vendor. So that's how it will work. That's kind of the effort to not make folks have to liquidate their own funds. But you will have to go down the road of really like definitive purchase orders, invoices, and other things so that we know the true actual amount that's going to be spent. Oh, yes, sorry. Yeah, just really what that meant is like this isn't just kind of like something to cover your ongoing operating expenses as an organization. If there are operating expenses to an initiative or proposal, certainly like this goes towards that. Yeah. That's more just kind of like your general operating budget line. Can't go towards that. Yes.
The expectation that as you complete a year, there's an immediate sustainability, or is the expectation that over the 5-year period, a sustainability path is created?
I think especially here in year one, a little bit of both. I think part of your sustainability plan can the multi-year initiative project idea that I have, and our initial sustainability is to reapply for these funds over the next 5 years. But then certainly if it's an effort, I mean, there's some things here that are kind of one-time purchase type things. Those just kind of naturally have sustainability. But if it's, efforts, initiatives, again, that the plan is for them to live beyond the 5-year funding, that's where kind of the overall sustainability of, what are our ideas for providing funding or transitioning this to, a different model that's more sustainable in the future.
Is there a local cost share or local match required?
No match is required. And then the definition of rural is CMS, HRSA's definition. I know there's a lot of different, even federal definitions of rural out there, but that's what we're going with. And also, I think it was Yeah, it's on ADECA's website. The state's plan, the kind of 60+ page document, in the first section kind of details some of the definition and description that the state used, and that's kind of our general basis. But the HRSA definition is a good kind of rule of thumb there. I think there's right here.
Comments earlier suggest that asking for replacement of EHR outside of that would not be considered misinterpretation.
I think within the state's plan, it doesn't kind of like strictly consider that like full EHR replacement for folks who are already on it. It's really more improvements on your current system, interconnectivity. It's really more about interoperability and data sharing than new AHRs. And also knowing that even 5% of 200 million can go pretty fast when it comes to an EHR replacement. I'm not sure the state necessarily wants to go down there, but that doesn't mean you can't include it in your application. But I think it's more the earlier, again, that's why it's called like the collaborative EHR IT. It's really thinking about how are folks talking to each other, connecting to each other, data sharing and things like that. Far back. You. Sorry. And then you next.
And adjudicating applications that are into areas that already have that service. A rural hospital already employs physicians, and this entity maybe is not applying, but they feel like the things that are coming in to achieve transformation for their workforce might be colliding. You know, what sort of reconciliation is going to be done so that I understand that if there are multiple applications for the same geographic area, there will be a natural reconciliation. But what about the things that are sustainable already and are not applying? What reconciliation or authority will take in participate upon?
Here's how we see it. You send it in, you put it in the application, we look at it, we rack and stack it like a blindfolded lady, like we do any other grant application. We select what we feel like is the best application. We send it to CMS, and CMS will either concur or not. The question in reference to the advisory group, we see it working like this. With broadband, it's been very successful with our internet service providers, and that it helps keep you on track, and that if you are awarded, because of this program running at such a rapid pace, and it's our intentions to have you back in front of the advisory group every 30 days to give an update on where you are as to spending the dollars, so that we can stay on task and making sure that the dollars are out the door by or before October of 2027.
So for those of you who, we've been working for 8 years, I think, in the state with our broadband initiative. And we have achieved a high level of success in deploying broadband throughout the state of Alabama. We're not finished. We still have work to do. But the consulting group that ADECA hired, brought on board to help us with broadband has been invaluable. And we wouldn't be where we are in the state without the help of this group. And I'm very confident in the direction of choice with PDO that they're going to provide the same level of expertise in helping us deploy these funds. As David said earlier in the presentation, we want to make sure that we spend every dollar that's available to us in the state of Alabama this year and that we do a good job with the applications so that next year we have the opportunity to have more dollars. So they're going to do everything in these workshops to make sure you're successful with your application and give you the technical assistance that you need, just like we've been able to do with the internet service providers and the broadband to make this program as successful as we have been with our broadband. Thank you.
It goes here and then here. Indirect cost.
No, that would be. So indirect costs and admin, there's not gonna be any allowed. It actually, all of the funds that you're applying for are going to go toward the activities within the initiative.
Ryan, you had your hand up 5 times.
Comments about process going through with that. Did I understand you to say, so if you've got application, draw the intermediary to determine whether or not they get to go up to the next level? And if so, is there a rubric that you're evaluating these various, you got one for several buckets, if you will? How do you envision making that determination, which, pass most?
That will be shared at the workshops as the NOFOs come down. That way you'll understand the rubrics and what we're actually grading you by.
A lot of us are here to work collaboratively. That's the entire point. Is there going to be a way to network with everyone that's maybe interested so that we might reach out and say, hey, we're interested in doing a mobile clinic, but we don't want to supplant anything you're doing. We want to enhance what you're doing. Is there any way that we could be connected with people that are interested and have those conversations so that we don't run into territorial issues or anything like that?
Yeah, I think, as we get applications in and as we continue to have conversations, I think the BDO team can have that as a takeaway of, how can we create some forums for communication and things like that amongst folks. Because you're right. I think the goal here is to foster collaboration. I think the state believes and CMS has a strong belief that through collaboration, you're able to have a bigger footprint and therefore a bigger impact on rural healthcare. And certainly, we want to foster and facilitate that the best we can. In saying that, I think the state and many states in this program have kind of, I think, made the good decision of letting the people dictate what that collaboration looks like. Seeing all sorts of different flavors of that in different states. But if you are applying kind of collaboratively, having, MOUs or letters of intent are things from folks, if you're kind of applying on behalf of a collaborative effort, is certainly something that we would love to see in your applications. Yes.
Program. Are there any limitations to those?
Limitations is essentially the budget that we have for those dollars. But I will say, remind again, I think the probably stronger thing is the 5-year commitment that goes along with those dollars. And certainly that's something that we want to be as upfront as possible with people who are looking to receive these incentive dollars to then pay out to providers, but that providers are 100% aware of that requirement. So there's no CMS cap that I've seen on how much those incentives can be, but we'll go back and check to make sure that there's not any fair market type sizing that we need to do. But I have not seen caps on amounts, if that was what you're asking.
Go to a 4-year institution and protect the housing like that type.
Yes. Back here. I don't believe so. We kind of have to separate health shortage areas and rurality. They oftentimes intersect, But I do not believe that Montgomery fits kind of the definition of rural for that. Yeah, it's not to say there's not a need, but it's just not a rural need. Here.
First question, say you were to incentivize somebody to go to a four-year institution in exchange for a five-year commitment to work in rural health. Say they don't fulfill that commitment, is that then on the organization to repay CMS? Or is that transferable to the individual specifically who didn't follow through on their commitment?
You want to? It's a good question.
So that question has been asked a lot from the state. Essentially, when an individual is given an incentive, that five-year window, again, now if they're going to school and then later they're gonna go into the workforce, I believe that's when that five-year window would happen. However, if they don't fulfill that five-year window, I guess, before that, we would suggest that if you're gonna give someone an incentive stipend, CMS doesn't like the word scholarship, so we use educational awards. To get them to sign some type of contract that says, if we drop out, you have, or leave the rural workforce, you have 30 days to pay us all this money back. Essentially, CMS, the state would be, ADECA would be tracking the amount of students that are in the program, which would actually be filtering for you guys. And that would continue on past the end of this entire program. Someone got awarded a stipend year 5, that 5-year window starts then. If they don't pay it back, it is on the subrecipient in the state to send that money back to CMS. However, CMS is not giving guidance on how soon that money needs to be returned. In cases like this, usually it would be seen as, this is a beneficiary. And once it hits the beneficiary's hands, all federal requirements are out. But in the case of this, even though it goes to them, they are still not technically a beneficiary anymore. They are, I would say, an asset to the program, and they have to fulfill the requirements of the program. But as I said, we're still getting guidance from CMS. I think every other week they issue about 5 new FAQs. So eventually we will get a solid answer on that piece.
Yeah, figuring out the full expected functionality of this 5-year work requirement is a burning question from basically every state. So we hope to hear from CMS soon on that.
ADECA is the agency that is charged with managing these funds. So whatever entity we enter into an agreement with, that's who we are going to expect and hold responsible for any of the requirements.
We can't go looking for those individuals. Joe made grant awards. I'm coming to you.
Yes.
The funding per entity. If you would submit something that's $1 million and it's such whatever initiative, how do you do the grant award? Is it pro rata because everybody's asking for that money? Is over the threshold adequately, or is it all or nothing? And then each initiative might have some overlap. So do you kind of look at that as a factor for kind of one initiative bucket versus the other?
Yeah.
Let me just be sure that I understand what you're saying. That we don't have enough money to go around basically for quality initiatives. And I believe it actually states this in the NOFO, but we do reserve the right to fund all parts or none of the application. So, we can look at that once we get them all in.
Program based on points, and is that transparent?
It's not been determined at this time. I will look at that.
When we have those workshops, we will be happy to make sure that you are aware of that. But it is a good question.
Yes.
the application's grade will be based on percentage of.
I think our expectation from applications is that 100% of these dollars have to go towards impacting the rural community. You can't, I don't think organizations can kind of, who serve both populations, essentially kind of have to separate these dollars just for your rural populations. CMS does not want these dollars to go to like serving urban communities. That makes sense.
Back here to your left.
You have access on what CMS is seeing out when they make these changes, or and we don't have access, can you send those to us as soon as they roll out?
Yeah, so, with CMS, they do post it on their website for rural health. And then when updates do occur, they let the states know that it's happened. But what we can do is if it does get updated, outside of what's already on their website, then we can email blast and let you know that they have updated the FAQs again, and there's going to be certain areas that have changed. So everybody's aware of what's going on. As we spoke about it, CMS is issuing new FAQs regularly. So we will see how many more get pushed out.
Yeah, I don't know the URL off the top of my head, but if you just search like CMS Rural Health Transformation Program, the first thing that'll come up is the link to like the CMS landing page for this program. And at the bottom of that page, they have, as recently as they've posted, FAQs are at the bottom. They also have the National Notice of Funding Opportunity that if anybody really wants to nerd out about this program, I welcome you to read it. It's a very long document as well. But has a lot of the real minutia about the program. But it's all there publicly posted. Yes.
I need to be in the rural county track, which is necessary.
It is not a requirement to be physically located or headquartered in a rural community. Again, like one of those things like a health system with a rural footprint might not be headquartered. But again, part of the application will be, what is the anticipated rural impact of my proposal? And I think those organizations that aren't at least headquartered are located in a rural community are going to have some pretty strict scrutiny in their rural impact of their proposal. That strict scrutiny is kind of required as that earlier question. I mean, CMS is going to require that all these dollars go towards impacting rural communities. And that's a pretty strict standard that we have to have. So that's kind of how maybe an urban headquartered organization, kind of has to show how they're accomplishing their goals exclusively for rural Alabama. Yes.
You anticipate a centralized office or centralized organization applying for the funds for the 5-year commitment piece, or do individual institutions need to apply for those funds?
I think both are on the board. I think to the extent that centralization of effort can happen, that's possibly for the best. But it's going to an open application process because there might be instances where individual organizations make sense to access that. But I know and understand that a decent amount of planning has to go towards new, especially GME slots. But also know that there's possibly startup costs that can be year one type asks, and then the future costs going forward. But both are on the table. Yes.
preference, that is identified in our state plan. We have identified some of those, but as Director Boswell said, anything that will be prioritized and the scoring will be discussed, in those individual initiative workshops where we go over the application process.
Follow-up. During the supporting process, will there be any collaboration with potentially the Department of Mental Health or Department of Public Health to verify and ensure that those services don't already exist in those rural communities?
Yes, if we have questions or concerns or need to collaborate with our partners, we absolutely will do that when reviewing the applications.
Is there any other question? There being none, we ask and invite you to apply. We are on a fast timeline. I cannot apologize for that. It's not my timeline. It's CMS's timeline. But we will do everything within ADECA's power to get this money out, but we cannot get it out without your help. As David had said earlier, we could get more if we can get the money out the door or obligated by the October of this year. Or you know what, we could get less if we don't get it obligated. So we are depending on you to get us good applications that will actually improve rural healthcare, transform it, and sustain it. So ladies and gentlemen, I know that you're on a short timeline. We are too. But we will be having those workshops. We too are putting this plan together as we fly. Because as BDO had just alluded to, we're getting changes every day. But we're adjusting to them. So we ask that you have patience with us. We're going to try to have as much patience with you. But we do ask and invite you to apply. And thank you for the attention and thank you for being interested in the program. Thank you.